Welcome to the 17th hands-on colonoscopy training workshop. We'll make a start. Before we start, we'll just do a recitation from the Holy Quran. So, as I said, it's 17th hands-on colonoscopy workshop. So we've been doing it for how many years now? 20 years or 25 years, something like that. 17th means like probably 20 years, isn't it? 2012. Since 2012, the course has obviously we've made changes to the course. We've lot of things have changed as well. So that's we've also sort of changed, and obviously from the old unit we've come to the new place. So in this place, this is our third colonoscopy. I think third colonoscopy workshop. So informal सा है, ठीक है. So there is no formal way of doing it. Nobody is senior, nobody is junior. All the candidates are allowed to ask any questions. We've got an excellent faculty. So Paul, he's our international faculty. He's from UK, and he's been running this course since it started 12 years ago. So and a lot of the things that you see in this unit, from the quality improvement wise and SOPs, this is the guy who's helped us and who's made all that stuff. So we are grateful to Paul that he's come all the way from the UK. He's actually come for a family wedding event, and he's sparing his time in the morning to come and teach us. So thank you, Paul. The other faculty members, we have got Dr. Afzal. He's a gastroenterologist in Patel Hospital. Again, an excellent endoscopist. He's been he's been in this course initially, like long time ago when it was started, and he's also done a trainer with us as well. So thank you, Dr. Afzal, for joining us. And we've got Dr. Mansoor, who's on his way. He's stuck in traffic. He's also a gastroenterologist at Liaquat National Hospital, and obviously very experienced. And then we have Dr. Asim. He's been with us for quite some time, and he's an excellent endoscopist. He does all our advanced endoscopy procedures, and he did train the trainer with us last year as well. So it's very nice that people we are training, they are now stepping up as a consultant and training other people, and that's what we want. That when we've trained you, we want you to train the next generation and pass on. And then lastly, we've got Dr. Novel, who's also on the way, and she's one of our faculty members as well. So I'll give it to Paul to start off. I think we just usually do it that we get an introduction from all the candidates. If Paul, you want to say something? So when we do the introduction, we would want name, how many cases you've done, and what do you want to do, what do you want to achieve in this course? What's your aim? Why have you come for this course? Is there anything that you want to improve on, anything that you get stuck on, anything that you want to understand? So we'll write all of these things down, and then at the end of it, we'll go through and see whether you got what you want.
Good morning. My name's Paul. I've been performing endoscopy for many, many years. Too long to say now. 1998, at least, is when I started. But colonoscopy wasn't taught back then in the UK. Colonoscopy was just, you got on with it, and then if you got into difficulty, hopefully someone else was there to help you. It was refined, and we brought in courses that helped develop a lot of services. In particular, was developed was JAG accreditation courses, and this course in particular is based upon all the JAG recommendations, and everything here that this unit provides is actually looked at how you can provide the best practices and the best procedure, how to actually create the best opportunities for you to learn, but also for the patient's experience. It's about patient's experience. It's not about what it is, what you The patient is at the center of it, not you. Even though it's you that's doing the procedure, there is the patient there. So we actually look at patient safety, how comfort the patient is, how quality is going on, your communication with the patient, etc. Hopefully you'll take away a lot of little things, and then when you put it all together, it makes a big difference in your practice when you go back. We will be having little inuits talking to you, pointing out a few things. Don't take it as an offence if we say and use a word called stop. If we say stop, something's about to happen, but it's also a learning opportunity. So when you hear the word stop, it's not there to tell you off. It's a learning opportunity. That's what you've got to look at. Now I'm going to stop because I'm going to bore you if I continue. But what I'd like to do is hand over to whoever's the next candidate. Give your name, where you're from, what your current experience is as how many procedures you've done, and your cecal intubation rate, if possible. And what is it that you actually find difficult to do? Is it that you find it difficult to negotiate the sigmoid? Is it that you find it difficult to retrofit the scope in the rectum? What is it you find difficult to do? And then we'll see where we can go from there. But most importantly, what we want you to do is enjoy yourself. Anybody who enjoys the learning experience actually learns more. Those people who don't enjoy it, then they close their mind to an opportunity that's there. So what I'm trying to tell you is we're here to give you a comfortable, happy learning experience. And if you're not happy about something, you've got a mouth, please use it and express a concern. Okay?
Assalamu alaikum and good morning. My name is Dr. Sultan Ahmed Jandio. I'm working as Associate Professor of Medicine at Chandka Medical College, Ladkana. Since year 2011, we are doing endoscopies in our medicine department, and at that time there was no gastroenterology department at our institute. So we have a lot of the burden of liver cirrhotic patients. We were the persons from the medicine. So we started have upper GI endoscopy from 2011, and then this continuous process was there. We have learned things. I have been trained in Services Hospital Lahore under supervision of Professor Aftab Mohsin. So then it was a continuous process. We have the experience of upper GI endoscopy. For last 1 year we are doing the colonoscopies, and later on GI department was also there in our institute, and it is also working with collaboration to the medicine, but still there is need. So what is the objective of my sir, from last 1 year I am doing that, and we have the colonoscopic opportunity 2 to 3 cases per week. So roughly 25-30 cases. And my experience is that I have difficulty in intubation the cecum and ileocecal valve, and I want to learn some of the tips and tricks from you people. And mostly I have the difficulty after the hepatic flexure. Then there are certainly loops are developed, or the intubation rate is very low. So that's why I joined this course. Yes. And do the full colonoscopy. Yes, sir. Mostly under sedation, but we give the low minimum air, and mostly our patients are comfortable.
Hello, Assalamu alaikum. My name is Dr. Umar. I'm working at Patel Hospital, and I've been I've had 2 years of experience post training, and I do like 7 to 8 procedures on like alternate weeks basis. And my aim would be to improve my maneuvering of the loops and difficult bends, and many a times I read cecum, but then I can't go into the terminal ileum. That's likely due to the loops. So I want to improve on that, and I do work for improving. Sir, I don't have a track, but it might be more than 100, maybe.
My name is Dr. Rahil. I'm working as an assistant professor in surgery. So most of the time I do upper GI endoscopy in surgery unit 1 with Dr. Sajida Qureshi. So the good news for Paul is that he don't have to work like unlearn and then learn. I'm basically learning the proper techniques. So my experience with lower GI endoscopy is minimal. So I then 15 or 20. When I had done when we were in surgery unit 1, this endoscopy unit was established in surgical unit 4. So since long I have forgotten. So we have to learn from the beginning. Okay. Most of the time I usually get stuck in loops. So it was most loop formation and then release.
Assalamu alaikum. My name is Uruj Afzal. I'm a senior registrar in OMI hospital, and I've roughly done 250 colonoscopies, 250, yes, and I want to learn loop reduction techniques and TIA intubation.
Assalamu alaikum. My name is Dr. Najib, freshly enrolled in gastro fellowship in Shifa International Hospital under the supervision of Dr. Shizad Riaz. I have performed 20 upper GI endoscopies under the supervision and limited withdrawal in colonoscopy. My aim is to get exposure to the colonoscopy technique and withdrawal and reduction of loops. Yes, I am. I'm sorry.
So everybody said loop resolution. When you say loop resolution, do you sort of do you recognize some sort of which loop you want, or do you just see that it's not going in? So how do you guys recognize the which loop?
Yeah, sometimes even not.
Not moving forward. So what do we call it? We usually call it one-to-one movement. So there's no one movement. Okay. What else? Not moving forward will be before not moving forward. Patient will have a lot of pain. You're not moving forward, pushing and pushing it. So the first thing would be the patient looking at the patient if he got pain. Moving it. Sometimes they don't say anything about the pain. They just move or they just play. So you know that you're doing. Anything else?
Mostly when I'm in the cecum, and that's the point I feel there's something wrong. So I want to know when I'm crossing the sigmoid colon, that at that time I want to get rid of the loop so that I can go on smoothly.
Because a lot of the time when you go with the loop, sometimes you may end up reaching a second colon, but then the last bit you start to because you
Huge scope guide. Okay. So a scope guide is used here, and that will enable you to actually see something that has been created by yourself, which is a loop. Often there is this myth that you can actually keep advancing the scope and you'll be able to get round completely without forming a loop. There are occasions you form a loop and you can't resolve it until you've actually got virtually all the way around, and that's when you can resolve it. And quite rightly, what Shanil is saying is how do you recognize whether you've got a loop where it is anti-clockwise is going to the best way to resolve it, or clockwise is going to the best way to resolve it. And what we'll show you in a short while is things of how to actually diagnose what kind of loop you've got. Is it important to know what type of loop you've got? Is it important to know what type of loop you've got? Why? I would say to you that if I had a alpha loop, I would be actually looking at doing a torque and then withdrawing the scope and then continue with that torque that you apply that's got the least resistance. Now, if you've got any other loop, what would you do? You'd apply torque, you'd withdraw the scope, and you'd go in the direction of the least resistance. So the importance of knowing what kind of loop it is not really something we should lose sleep over. It helps you visualize what you should be doing the first time round, or what you could be doing the first time round, to reduce the amount of effort you're putting in, the amount of times you're trying to resolve something. That helps. But an understanding of what the scope is telling you, and that's what it does. So if I was to say to you, the scope is an extension of your arm, what do you think? What would you think if I said to you, a scope is an extension of your arm? You can control it. What's the best way of controlling your arm? And trying to keep it as straight as possible. So when you start to feel there's some give, you're advancing. And if you're advancing 2 centimeters and you feel that you're only advancing 1 centimeter on the screen, you need to then start thinking, I may be forming a loop here. So you could actually then start to think about applying a particular torque. Or you could actually be thinking about changing position of the patient. What's the importance of changing the position of the patient? Okay. Anything else? Very similar to what he's saying there. You change the position of the patient. The colon sits differently in the abdomen. Does it do anything else? If I take the person from the left lateral and ask them to go onto their back, what does that do? It applies 90 degrees of torque in one direction, as well as changing how the colon sits within the bowel. So when you ever do anything like that, now you've actually applied torque, what would you do then? If you just applied torque, would you advance or would you withdraw? If you just withdraw. So if you then change the position of the patient, what do you think you should do? You've applied torque indirectly. So what should you do? You've already applied torque by changing position. If you've taken from left lateral onto the back, you've applied 90 degrees of torque automatically. So what you would do then is draw back the scope. But what is the most important thing to do and ensure when you are withdrawing the scope? And you're thinking about withdrawing. So make sure the tip is central to the lumen so that as it withdraws, it wants to go forward. And when the tip steps forward, it'll step forward, continue to come back, it'll then come back, and then it'll go forward. Then you come back another centimetre, then you can keep that torque on. What happens is people let go of the scope, and that's when the torque fails, and then you re-loop. You will automatically re-loop. So you apply the torque, withdraw the scope, keep it central as it comes back, and then advance with that torque on. And we'll show you that when we demonstrate it outside the body, how that works. So that should help you with regards to that. that should help you with regards to the loop. But you've got to understand what the loops are first of all. Now, sir,
Can you just introduce yourself and just tell us how many procedures you've done and what is your aim of the course?
Dr. Zulkarnain Haider,
Where do you work?
Nishtar Hospital, Multan.
Bhutan. So how many cases have you done? How many colons?
Almost more than around 100.
Around 100. And what is your aim? कोर्स में आने का मकसद क्या है? क्या सीखना है?
Aim to improve further skill.
कोई ऐसी चीज जो आपको when you do the colonoscopy you find that you are stuck in that, yeah, you find every time I get problem with that you want to improve?
Mostly facing problem of loop formation and removal of loop.
So most of you guys have said about loop formation. Acha, sometimes it's difficult to understand Paul, people who've not heard him for the first time. So if there is any problem, that's something that you don't understand, he is more than happy for you to ask even 5 times. He will answer you back. So don't sit back if you don't understand. It's understandable. Even he knows. Even we sometimes don't understand him. So if there is any question that he's answered and you want to get it repeated, just tell us and then we'll be happy to answer it. Yeah, we've got Dr. Sajida here, who's our course director. So I think we go on to talk about so one thing that Paul said about loop reduction, when he said that look at the screen and all that. One of the things that people do here is they lock the wheels. So one of the important bit is when you are reducing the loop, just make sure the wheels are unlocked, definitely unlocked, because you don't want to reduce something not looking at the screen and the wheels are locked and then you reduce it and then it causes problems.
can I ask then, you mentioned locking the wheel. How many people lock the wheels on the school? You lock them. They go, what do you do? You lock them. Don't worry about that. You lock them. You lock them. Anybody who lock the wheels? You should never, ever lock the wheels. The reason why the lock's there is that for looking at, keep the tip stable in the direction you think it. That's what the thought behind it. The lock of wheels, I don't use it for. Try the wheels hit the boat, then you do the wheels, get the locks on. Never apply the locks. The thing that causes the scope to feel stiff is you. If you feel stiff, the scope will feel stiff. I'm showing you that before. Just relax. Relax. Don't lock wheels. You've got it, you'll cause a problem. Not just cause pain, you will do damage to the patient. You can tear. Complications.
Do you have
There was a slide, there was a presentation in the previous one. What we can do is just go through as people think of complications are.
or
I think the best thing to do while we're looking at complicated is actually to come and get an idea about what we'd like to think about the scope. So you can come forward on the candidates and anybody else would like to come forward.
come forward candidate.
So, So every one of you have the scope, as I would say, correctly. Now, one will say correctly, one is correctly. Scopes with the umbilical down the inside of the arm. What's the importance of the umbilical down the inside of the arm? You'll see people who will say, no, you need to hold it this way. Why is it wrong?
Because it will be a lot of difficulty in handling the wheels.
What kind of difficulty? I mean, I can still read the wheels.
Number two, there's also looking over here.
No, that's just because of the way this is. I mean, if I did that, then you're going to still do the same thing. So I'll just put that there. So what's wrong? Is that the right way? But you did it this way. And I said, that's correct. And I say, that's wrong. Why? There's a couple of things. You're right, but there's a bit more to it. When you've got the scope like this, I'm going to do something I've told you not to do, but it's for demonstration purposes. If I hold the scope like this and I point my fingers forward, I do that, the scope will turn. If I hold the scope like this, the scope won't turn. Why? Don't look so serious. Why?
Because the movement gets traveled down there.
Absolutely. The arm actually stops the movement being transferred into there. So that enables it to come here. As soon as you do this, so that's the importance of holding the scope correctly. Next, when you let go of the scope, you can easily regrip. If you let go of the scope, it's gone off to that side. What's the importance of that? Some people do scope this way, but what's going to happen in the future? Carpal tunnel. We're seeing a lot of injuries now in scoping. I can list you them. Got bad neck, trigger finger, trigger thumb, all these type of things. Remember when I started, we were doing them slightly differently. Back is killing me, shoulders are killing me, all because you're standing, you stoop, you're looking over there rather than looking straight ahead of you. So what am I trying to get you to think of? The most important thing is patient comfort. But how can we make sure the patient is going to have the most comfortable experience?
By being comfortable ourselves.
By being comfortable ourselves. So if we then look and control the environment, so if I was to scope like this, I've now got tension on my neck, I'm looking over there, this shoulder's slightly higher, I'm dropped down, my back is here, this leg is straight, I can't do much. If the screen is in front of you, I can then adjust myself accordingly. So you've got to look and see, can I stand square? Can I do this? Can I do that? It's important. The next thing is looking at how your legs are. Because if we just move that just to one, can I go on that? That's brilliant. So if I look at where my legs are, if I actually point my leg to the right and turn to the right, the scope will turn. Holding this. If I put my legs there, the scope will turn. Now, remember when we said about the patient going onto the back? The patient goes onto the back on the scope. But the patient's gone onto the back from the left lateral. So they come here, gone onto the back, the scope has actually gone that way because the patient's come this way. So we've got to understand what's happening to the tip. What makes it difficult for us to understand what's happening to the tip is as simple as this. We look at the screen, and I'm going to keep this on the black mat. If I pull this back, you'll see it goes there. Yeah? So which direction is it going? Going to the left. Well, what's it doing on the screen? Up and down. So I pull the big wheel back, the tip goes up. Now, is that because it's in that position? Now what we're going to do is rotate it 90 degrees. And what's the tip doing now on the mat? So what's it doing on the screen? Still going up and down. So what's happening is that you've got to understand what is happening with the tip. So when you put the patient onto the back, it's 90 degrees, but the scope is making you feel, what's going on? I don't understand. You've actually changed the direction, but with the scope, how it's orientated, but the scope's still going up and down, but I can't understand it. So these are the things you've got to think of. What are you doing, and how's it affecting the tip on the scope? So one way of knowing what that does is you've got the scope, I pull the scope back. I know I'm going left and it doesn't want to go forward. How do I know what direction I need to go? I pull the scope back. That's anti-clockwise, that's clockwise. If I have a loop in the scope, that often changes the direction about how the scope feels. So now, if I want to go left, and I want to go right, but these loops feel tight. So what I'd like you to do, I'll hold the scope. Just hold the scope in your hand. So hold it like this, in your hand. Not just that hand. Now I'd like you to apply a clockwise torque slowly. Is that clockwise? So I'd like you to apply a clockwise torque. How does that feel? What about? That's because of that. So if you were to withdraw, how does that? Slowly withdraw.
Withdraw.
Yeah, withdraw. How does it feel? That's to advance. I said withdraw. How does that feel? Is it getting more difficult? Right. Put the scope back, hold on to it. Now slowly apply anti-clockwise. How does that feel? Go back clockwise. Yeah, now you're neutral, now go back clockwise. No, that's anti-clockwise. So, clockwise. How does that feel? What's that telling you? What's it telling you?
We need to have the shaft straight.
You need to have to show, but I'm actually applying clockwise torque and it's getting stiffer, harder as I withdraw, advance. I only did that, that's getting harder to withdraw. I apply anti-clockwise, it's getting more relaxed. So what does it tell you? It's a loop formation, but what does it tell you is a safe thing to actually start performing? So now, is it important that I know what type of loop it is? I go this way with the scope. I go anti-clockwise. And now I'm getting the effect of when I was clockwise. Is it important to know what type of loop it was? So what is it? What am I actually getting you to actually think?
Then it's always safe to go clockwise.
No.
When you feel resistance, move up on opposite side.
Slowly apply the torque to the opposite side. What you don't want to do is, as what if you read some of the old books, Cotton and Williams, apply clockwise torque and withdraw. That's what it sounds like. What you do is the word slowly was always missed. Anything you do when we're doing this procedures, we use the word slowly. So what's the word that I've used already this morning that I said don't be frightened of? Stop. What's the second word now I want you to realize? Slowly. So slowly apply clockwise torque, stop, slowly withdraw. It starts to feel tight. Okay, go clockwise. It's gone tighter. Continue with your anti-clockwise. Clockwise, slowly withdraw, stop, continue withdraw. If you notice, I'm not letting go of the scope. I'm applying the torque. And as the torque comes back, keep going. Okay, so now we're going to try. Close your eyes, my friend. Close your eyes, stand square, look happy. Close your eyes, trust us. I'm not going to rob you, unless you're rich. Now, what?
This is harder.
Yeah.
When I go clockwise, it is harder.
Yeah.
When I go anti-clockwise and slowly gradually.
Right, so walk backwards. Walk backwards.
Go backward.
Walk backwards slowly and apply the torque as necessary. Ah, you hurt me. You opened your eyes. Go on, walk backwards. Walk backwards. Don't let go of the scope. You let go of the scope then. I've seen it. How far have you walked backwards?
2 steps.
You were here. You've walked back. So how much do you think you need to withdraw the scope? Let's do it again. You have a go. Close your eyes. Trust us. I'm a heathen. Right, my friend. No. Hold on to it. Have you got it? Right. Apply the torque necessary. Walk backwards. Keep going. Keep going. Keep going. Keep going. How far have you walked backwards? So how far would you normally, if I said to you, stand where you were, which was there, we'll go back to this. Now just hold the scope where you did. Now just withdraw the scope. Don't walk backwards. Just withdraw the scope. Just withdraw the. Can now you safely reduce that loop by just standing still? Difficulty. So what I'm trying to get you to understand is that when you do not necessarily move backwards, is that you have to take out more scope than you think. By visualizing it how far you walk backwards, it shows you that pulling back on your arm and getting to the full extent of your arm is often not enough to withdraw and reduce the loop. So what you need to do, if you remember what I said earlier, you need to be able to re-grip the scope. See how I've got the scope? Through the fingers. You can then re-grip the scope and continue with the scope. You can re-grip the scope, continue with the scope. Mike. Hello, Mike. How you doing? That's my middle name, you know. Paul Michael. Well, Mahal. See, so you do have to step back. So when I said to you before that if I scope, these guys will tell you, I actually move. No, I'll just move to the side. I'll move here. And that's to keep the scope in a straight line. So if I move from here and just keep coming back, I'm having to do this and lean over. Whereas I'll step over and come back with the scope. So, just to recap, you've said nothing for 5 minutes, and I'll pick on you in a minute. So, what have we said?
You have said that instead of pulling it back, you have to step back and then feel the resistance during the torque.
Yeah.
And rotate it clockwise.
So, what do you think I've said? So it's backwards. So what we're doing is we're feeling which has got the least resistance. That's got the least resistance, but I'm not asking you to go completely. Why do you not apply the torque completely? Why do you not suddenly go, I'll do that, withdraw, as in what they would say in the old books? Why? You'll be, some trainers will turn to you and they'll say, right, your bosses may turn to you and say, apply clockwise torque and withdraw. Why would I not say that? Why would I say slowly apply and slowly withdraw?
Because it gives time to.
Time for one, but what's the most important thing? Okay, we'll show you. Here is the scope. Here is the loop. I draw back, apply clockwise torque. How much scope now is taken up in the peritoneum? What's that doing to the colon? What's that doing to the mesentery?
Stretching.
Stretching.
Yes, stretching.
So now I hold, can you just pop your finger on there? Just a finger. No, just a finger. So you draw back, 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 you draw back. You see? And you're not half the space you're taking up. Even less. As you draw back, no, it's all right, just get your finger there. And then you come back slowly. Yep. So, and what I'm showing you here is just finger there just stops the scope. So all this is just how to actually manage the loop itself. So what don't we do? What don't we do? We don't apply the full torque. We go anti-clockwise. Oh, it's stiff. And that's why it's stiff, look. And that's doing it in the patient as well. But also it's stiff because it's pushing against this. Then we draw back. We go, oh, that's least. It's getting tight now. Clockwise. Oh, it's no. Anti-clockwise is continue. You do check. On, off, on, off, on, off, on, off. Keep coming. On, off, on, off. Yeah. Practice. Practice. I'll hold this. See how you got a bend in the scope. Try and keep you in a line. So what we've got is when we actually scope a patient, we'll put the scope in. A lot of people put the scope in and they'll scope, yes? But they'll pull the hand here. So now you're scoping and the scope's going in this way. That's very similar. So as you come back here, now keep that in a straight line. That's the anus. Keep coming back. Apply your torque necessary. Apply your torque necessary. Keep coming back. Keep coming back. And keep coming back. Okay? There's no tension on this whatsoever.
We have to keep it fixed.
What's fixed? No. This is just to demonstrate to you how to decide which way direction to turn the scope. So when you're withdrawing the scope, what I'm trying to get you to do is feel the resistance and the stiffness that is formed when you're applying your torque. So if I apply a clockwise torque here, it's stiff. It's forcing this up. It's forcing this down. Think of a snowshoe going into the snow. It's a bigger footprint. Whereas when you're coming back, there's only a small footprint. So it goes cut straight through the snow. So this is why you're thinking about what is the best and safest way to reduce a loop. So keep withdrawing. Apply your torque.
My question is that time when we are slowly withdrawing, so
Yeah.
we have to keep the control when it's fixed over there.
This,
Yes.
right. You put a loop in to the scope. Okay, there's a loop in the scope. No, stand that side. Right. So I've got the scope here, just pressing that down there. So I know that that's the loop in the scope. Right, so we've got the loop. This, your consultant saying keep this still. Okay, so I come back and I do this. Watch this hand. I do this. So what does that tell you? It tells you that when you're applying this torque, no, you keep that on. When you're applying this torque, you could be fighting this because you're going to be doing this, right? So come here, stand still. No, no, you stand still. You come here, right? Hold the scope as what you would do umbilical down the arm. Right, hold this, hold that there. Now, apply a torque, apply a torque. Hold that there, apply torque. How does that feel here? That. See, you want to bring that round because he's feeling resistance in it. So in saying to you to keep that still, put that back, keep that still. Don't move that whatsoever. Now apply the torque. How does that feel? So, but here though, in comparison, why did you do that before? Because it made it easier. Because what you're doing is you're fighting two torques. You're fighting the torque in this. If you turn that there and keep this still, look at it. See it? Down here? Watch. All of a sudden, I'm fighting that. Whereas if I do this, makes it easier. But you don't break, as I call it, don't break the wrist. By breaking the wrist, that's this. That's carpal tunnel. What you're going to do is bring the scope up. So when I drop the scope down, bring the scope up. Drop the scope down. Do you want to step forward? You didn't think there's this much, did you? You didn't think there was as much as this. Yeah. So you've walked back 2 steps. Step forward again. No, no. Hold on to the scope. Hold on to the scope. That's good. Excellent. Now just do it with your arm. Don't move your feet. And you wouldn't do that, would you? So in your own unit, you wouldn't stand there and go, extend. What I'm trying to get you to understand is you do have to move. In shortening a loop, even if it's small, you have to actually withdraw more scope than what you think you have to withdraw. Okay? Prof. Shall we move on to playing with the mannequin? Stiffener, right. It's wrong to say I don't use a stiffener. I do use the stiffener on very rare occasions. What does the stiffener do to a scope? This is a stiffener. So what does it do to a scope? So it brings a rigidity to the scope. You see how pliable the scope is now. So if I apply that stiffener, what part of the scope stiffens? The whole thing. So all the way up to 1 meter 10. Okay, that's what you're saying. But you think just the tip, up to 20, 25? Okay. No idea. Guess. Go on. What's your best guess?
I think at the tip.
Tip.
I think along the whole length.
Whole length.
Mostly along the middle part of the shaft.
Middle part. So from where? 40 to, or 30?
42.
40 to where? Oh,
42 1 meter.
right. What's the purpose of the stiffness? What was the theoretical purpose of the stiffness? Avoid looping. Where was the most common places where they theoretically felt you looped? Sigmoid. So where do you think, if they kept a straighter scope, in theory, that they'd want a stiffer scope? So, but for the sigmoid. So when you apply the stiffness, let's apply it completely. This is the tip. Now here's the stiffness. Right. Now if we take the stiffness off, this is the tip, and the stiffness has gone. So stiffness itself, you should never put it on when you're advancing the scope, because it's going to cause the bowel to stretch even more so. Because it's stiff, it's going to force it out even more so. It's a tool. If you are going to apply it, you need to apply it and withdraw the scope. So if you're ever going to apply stiffness, withdraw the scope. Once you've applied the stiffness, then you've withdrawn the scope and you've reduced whatever is causing your issues, because it's meant to actually straighten out the sigmoid. Once this goes, then you can apply it and then advance the scope with the stiffness still on, keeping a straight sigmoid. That's what it's about. Why has it got numbers? 1, 2, and 3. Levels of stiffness. So, what do you think about the numbering system? Do you think it's good? Do you think it's appropriate? You've scoped. You've handled the scope more than 200 times. You've told me. Yeah. But does your scope have stiffness? I never use it. Yeah. But I'd say to you now, I drive a car. I drive a very fast motorbike. I drive all these things. Do I understand what every bit of it does? Yes, I do. Because I want to make sure that I know that when I'm going to do something on that said motorbike and on that said car, that I know what I'm going to do to avoid any accidents, any incidents. So it's not a get at you. It's before you pick this thing up, make sure you know all about it. So if your scope has got stiffness, you should know what it's there for, what the purpose of it, and don't necessarily how much to apply. Now I'm going to say to you something controversial. A lot of people say apply stiffness level 1, withdraw all it. Forget it. Stiffness level 1 does nothing to the scope. Stiffness level 2, it's just like pulling your trousers up. It just makes you feel a bit more comfortable. Stiffness level 3, if you're going to apply it, apply it. Right. So stiffness, with the older scopes, like this one, if you were using it in earnest, you would probably find yourself applying stiffness. Newer scopes, you'll find that you probably don't need to use it because they've got less flexibility in the scope itself. There's less wear and tear in the scope. So as the scope gets older. Now there's ways of making the scope feel stiffer. Hold the scope, that end again. So this is the scope. How does that feel to you, that scope?
It's one axis.
Oh. How does it feel now? Right. Why? No. 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 Why is it going stiff?
You have hold with force stiff.
So when I said to you earlier, your posture, how you hold the scope, if you're relaxed, so now you've got a loop in the scope. If I hold it and I hold it tight, that becomes even more stiff. I've just shown you with a straight scope outside the body, you look puzzled. Yeah. And you, being somebody who is developing the skills necessary, you get more anxious. And what do you do as a result? Whereas I'd say to you, do me a favour, put the scope down. You go, no. I said, put the scope down. Put the scope down, relax, pick it back up. And that, you've relaxed. Have a feel. So you got the scope. Nice. Yeah. And that's just because of the way you grip the scope. Just by gripping it. Is that what you think about stiff? What do you think about it? What do you think about the variable stiffness? How it make. See, the thing is, I'm not saying not to use it. But if it works for you, then use it. As long as you're using it appropriately. Don't apply it right and we're going to advance. Because you're going to stretch the bowel even more so.
But if I apply this stiffener on my withdrawing the scope, I don't get to turn it off. What would happen?
But once you've done advanced, no issue.
While we're drawing, you meant to say that while we're drawing, should we release the stiffness?
No, no. The purpose of the stiffness is that it goes forward. You've got an area where it's doing this. That's the sigmoid. And it's doing this all the time and you're pushing that up. To reduce a loop, you can't reduce a loop when it's this position. The tip of the scope is below the apex of the loop, right? The only time you can actually reduce the loop is I'm going to apply now a clockwise torque. I'm just going to relax my fingers as I do it. As I do it, then the scope comes back. Keep it on, and then the scope will go forward. So I'll show you. What if you step around here? You step there, hold the scope. You step here. Now just let that sit in the palm of your hand like so. This hand, yeah. No, let it sit. So as I do this, as I withdraw the scope, come back with the scope, apply the torque necessary, As it comes back, because I'm getting shorter on that one, as it comes back, the scope now wants to go forward. Keep coming and then go forward. But apply the torque. The torque stays on. What a lot of people do is they let go of the torque and then it'll reform. You pull it back. I've done it now. Instead of keeping the torque on and advancing the scope, they let it go and the loop reforms. If you've got the stiffness on and then you're applying it, that's the purpose of the stiffness. The stiffness is to keep this firm so that when it goes there, it goes forward. That's the purpose of the stiffness. So you withdraw, put the stiffness on, withdraw, keeps it going, but withdraw slowly by applying the torque, withdraw the scope, and then when you get to the point where the scope steps forward, so you'll see it on the screen. As she comes down, I'm just holding up there, watch the screen as it comes forward. See the scope step forward there on the screen? Or did you miss it? So we come back, scope now, comes back, scope step forward there, did you see it? Yeah. Just a fraction, now it can go forward. So the scope will step forward, telling you it's about to be ready to, but you still have to come back another 2-3 centimeters. Then it'll go forward. It'll do that shimmy move. Then you can go forward. But the stiffness, if you've applied it, stays on. And then you would take the stiffness off at the earliest convenience. Keep it on if the patient's comfortable. Doesn't matter.
So we have to use stiffness when we loop formation.
Not all the time. Not all the time. Reduce. I don't use it a lot.
Yes.
On the old, here you've got variable types of scopes. Older scopes like this, I'd probably use it. Newer scopes, I wouldn't use it. You wouldn't have to because the scopes have got less flexibility. They're more responsive. All newer scopes make, a lot of people look a lot better at scoping than what they are because of how good they are at helping you. New scopes do help.
Please repeat it again that when we can use the stiffness of the scope and and
Stiffness is personal preference. That's how he uses it, and he uses it more than I do. That doesn't mean I'm right, doesn't mean he's wrong. What it means is my personal preference is I don't like to use it. It's just me, I don't like to use it. I grew up in an era where we didn't have it, and I just thought it was a gimmick. He's grew up in an era where it was there when he first started. I'm 60 odd man, so I might not look it. I might look, but I don't look as good as him. But
maybe the way it is more benefited old scopes.
yes, that's what I'm saying. Older scopes.
Emphasizing. Most of us are using the old scopes. Yeah, most of the time. So it may be helpful, yeah. So it may be helpful. But it is, as I said, it's not one is not right, one is not wrong. You have to use yourself and get experience.
Because what will happen is you'll use a newer scope. Then you'll say, I like that scope. Can I have that scope again? No, sir, you got this one. That one has to be sorted out. Okay, well, you give me another one of the older scopes, and you've used stiffness. Then you get the new scope. You come along and you go, oh right, here's where I have to apply stiffness. So you do it straight away. Then the patient finds it a little bit more uncomfortable. You wonder what the hell's going on, because there's a lot more forgiveness in these scopes. Even when you apply the stiffness, there's a lot more forgiveness, because this scope only goes here. You apply it on a newer scope, it goes to there. So what I'm trying to get you to understand, the older the scope, the more wear and tear in the scope, the more flexibility in the scope. That's when you need to look at your options. And it's an option. The other option, which I've shown you, which is a very simple option, to how to stiffen up the scope. How can you stiffen up a scope? Grip it. I've shown you how that worked. What else can you do? Very old school method.
What's the question?
What's the question? The question is, how else can you stiffen a scope? So I've said you can grip it. What are the options? Old school method. These are things to make you think. You use an old scope. You've tried stiffness, it hasn't worked. You've tried stiffness and gripping the scope to try and stiffen it up. It hasn't worked. And I wouldn't advocate stiffening the scope too much, because it can cause trauma, it can cause a lot more stretching. But if you felt that if the scope was just a little bit firmer, it's buckling just at this point, very old school method, what could you use?
Can we use our index finger just to straighten the skin?
That's good, but it works really as you come down, lower down. As you come, down here, stops that happening, and that does stiffen the scope a little bit. What else can you do?
Just hold it a bit harder between thumb and index finger.
That's gripping the scope. What else can you do? You're included. You're included. What else can you do?
Maybe turn the pins to the max.
No. If you're talking about hooking, right, that can actually tear off the splenic flexure. You don't want to be doing this. So no, I do not advocate the use of hooking. It's a very old type of procedure that caused a lot of trauma, and it's only become evident with recent developments that's happened. And when I say recent, I mean the last 10 years. So what you can do is get a pair of forceps, pass them down the scope, get the person who's helping you to close the forceps as tight as possible before the bending section. That'll stiffen the scope. There used to be a stiffness device that you could get. So you'd get it, pass it down the scope, pass it out, draw it back 10 centimeters so the bending section stayed in, and then you'd screw it tight, and that then applied stiffness, but you lost your suction channel. So there are things out there that you can actually use, but it loses your suction channel. Why do you not want to lose your suction channel? Why do you not want to lose your suction channel?
Because then we won't be able to clear it.
Often when you've gone round, you actually apply your anxiety. You find it difficult. You apply more air. So you come round to get you through. What you need to be able to do is clearly suck and decompress. That then will actually hold on to the scope and allow the scope to go forward. So you're really putting the scope down, putting the forceps down, any other device in there, that actually takes out something that you require, which is a clear biopsy channel, so you can actually advance. So you don't really want to put anything in the biopsy channel. You don't really, but you need to actually keep that. The other thing that's important is remember you change position of the patient. Now, there is a lot of school of thought where you'll take the patient, you start off in the left lateral. Why do you start off in the left lateral? Why would you start off in the left lateral? So, who's more comfortable? Sorry? Left lateral. So who's it more comfortable for? No, but who's it comfortable? Is that left lateral, is it more comfortable for the patient or you? Okay. So who's it more comfortable for? Starting off the procedure in the left lateral? For us. For the patient. So we've got 2 for the patient, 3. My opinion, I saw Prof. Mansour. I'm going to ask you, I actually think left lateral is more comfortable for us because ease of access, advance the scope. The sigmoid is actually flattened. How, God forbid, when I started, we started with the patient on all fours. So the patient would be up on the bed and be like this. And then you start like that because everything dropped forward. Then you go forward. Then once you got into the sigmoid, you'd ask the patient to come down and lie on the left-hand side. Not all patients can do that, but it was not uncommon to actually start your procedures that way. So what would be the ideal position to open up the sigmoid and advance the scope, but wouldn't be as comfortable for you? What would be the ideal position for a patient to be in to advance the scope, give you the easiest way to advance the scope through the sigmoid? Maybe as a person in the right lateral. Yeah. So these are things that are difficult. What do you think?
For patient as well as
Yeah.
for the
Yeah.
Because it could be if the patient does not have any eye contact or anything left to the staff and the doctor, and that position is.
Yeah. So that's the importance. If you are doing it in left lateral, having someone talking to the patients all the time, somebody with the patient, even if they're sedated, the patients are aware of something's happening. So you've got to think of how can I actually optimize what I'm doing. So that what I'm trying to do now is emphasize the importance of the possibility of introducing the idea and concepts associated with moving the patient. So left lateral start, put the patient on the back, then bring them over to the right, advances. And now we're actually looking at mobility issues. Can the patient do this? Can we not? The advantage of doing that is that if the patient's laying on their right and you're traversing the descending colon, the air that you put in will sit here. When the patient's in the left lateral, the air comes round and it fills up the right-hand colon before it actually insufflates the left colon. And then that makes it difficult for you because it stretches the colon and it makes it more difficult to negotiate the bends because it makes them tighter. So you're sitting on the air. And what's actually helped us reduce the risk to the patient with regards overinsufflation? What helps in reducing overinsufflation? Suction, that's one. CO2. Why? Why CO2?
It is easily absorbed.
Yeah. So if you just wait a few moments, it disappears for you, which is easier. I'm not a fan of it because you have to practically sit on the button a lot. So what I'd like to do now is start. If we start with yourself, get a glove on, and then just you're not going to go all the way around on the procedure, but we'll just see how you do for the first couple of moments, if that's okay.
So far, what was the answer of your question? When we apply the stiffness, where it will be applied? At the distal part, or at what
When you can't go any further. When you can't go any further. When you can't go any
Which part of the scope is different?
Oh,
Numbers 1 to
30 to 80.
30 to
30 to 80.
Yeah.
And if we are applying more the numbers, means more the stiffness is over there.
That just increases that tension in there. But the 1 to 3, forget, just go 0 to 3. Just go straight to the 3.
So 30 to 80. Sir? 30 to
30 to 80.
30.
30 to 80 centimeters.
Okay. And one more thing, very, very basic. When you say torque, what it means?
Doesn't
Torque
matter.
right or torque left?
No. So anti-clockwise or clockwise. So torque is the one that's got the least resistance, the one that you find the least difficulty applying. The one that's got the least difficulty in you applying, that's the one you apply.
Okay. So when I feel resistance on any side,
Stop.
we have to stop and go another
No.
side.
If you feel resistance, stop. Continue to draw back. If it increases, that tells you you're increasing the tension in the loop. So then you actually decrease it by applying the opposite torque as you come back. You will find that you'll have to apply torque on and off as you come back with a scope. A lot of people apply one torque and they think that's it. No. The bowel, as it settles, is on, off, on, off, on, off. I can see you. Yeah. I can see you. Don't worry.
What is 1 to 1 movement?
1 centimeter outside equates to 1 centimeter inside.
Out.
Just to get a full relation. It should go.
Okay. So if I asked you to stop, what do you think would make it easier for you to continue? No, I've asked you to stop. So just stop. Don't let go of the scope. Don't let go of the scope. Hold the scope. So you want to apply anti-clockwise torque. What do you think would make it easier for you? Drop that down there and enable this to come here. How does that feel? Look at the scope now. Tip forward. Good. Anti-clockwise. Now, clockwise, whichever one you want. So it's actually anti-clockwise, like you were doing. And you see how this is here? See how this is here? Get that to there. How does that feel now? Now, stop, draw back a centimetre. Draw back a centimetre. Now go forward. Now let natural torque come in and tip up. There you go. And stop. How does that feel? So put the scope down. Put it down. Let go. No, put it down. Put it down. Let go. Let go. So what did you do differently? Did you do anything different negotiating that to what you would normally have done? In your normal practice, what did you do different here to what you would do with a patient? Yeah, so a lot of you will be told to keep this hand still. What I was getting you to do is look at, you can actually support the right hand by keeping this as straight as possible, and that enables that then to support the torque that you're doing here with the scope. So if you just on the bed, just rotate the buttons up. So turn the hilt so it turns upwards. Just turn the hilt. No, upwards. Watch the screen. Now, no, not lift it up. Just turn it up. Now turn it to the buttons to the table. See? So what we're doing is keep this straight. And even if it means you have to step to the right, it enables you to still move the tip. So all this that you're doing here with this hand You could be doing something opposite up here that's making it more difficult for you to apply the torque. So you've got to think of, now you know that happens there, how can I support what I'm doing up here? So I know that now, so I can actually apply the torque properly. Happy? Okay, take it out. Who's next?
So we have to also use this
Yeah.
one while talking.
Yeah, well, he's just showing you. Has he just shown you that's what you should do?
Usually just tend to keep this
And you fight
still.
it.
Yeah.
You fight it.
So we have to also like to and fro.
You have to slowly think of how this contributes to this. Now, come out. Right, stop. Look how you got your wrist. You step to the right. Bring the hand here. How does that feel now? You're keeping this in a line. That's what you've got to do. Now withdraw. So you know.
This position.
Right. When you actually apply the torque, you see this now? Stop. If he applied anti-clockwise torque now, this is pushing into the bed. If he wants to apply anti-clockwise torque, he should lift this, now apply anti-clockwise torque. He's no longer pushing that into the bed. You don't look happy. Good. You're next.
You mean to say we can do the clockwise and anti-clockwise position with single hand, and we have to not use simultaneously both of them.
Can I just, one sec. So what you've got the scope. It goes in, right? Now, just to wind you up, where's the gel? Right? That's on my hand. Right? That scope is here. So now as I go in with the scope, you don't have to grip the scope to get it to rotate. You just have to hold it back here and make sure that the apex is supported. You don't have to grip the scope. See it? All this hand is for support. The little wheel needs to stay neutral as much as possible. So it's always at 10-2. If you go in, you'll get an increase in this country of diverticular. That's the only time I tend to use it, trying to get through a diverticular segment. The little wheel and when you're trying to go into the terminal ileum. You've got this area here, you're asking me about what you need to do. So you come round, share it, the scope, it's here on the bed, and draw back. All this on the scope and the hand, you can transfer, you can do your torque with the scope itself. See it? You don't have to worry. Tip up, advance, tip down, draw back. Why have I drawn back? Because I'm over the fold. Tip up, anti-clockwise, clockwise, and then just keep it going. Anti-clockwise, bring it round. Advance. Keep it down, tip up, go forward. And I deliberately put that on so you know that I can't grip the scope. Hand sliding on the scope. This hand is really just supporting what this is doing. That's how I scope. What I'm saying to you is for you, you're going to learn this first with the support of this. And then eventually you'll rely more on this. And this just as a guide. This senses resistance. These guys will tell you, I will put deliberately gel on my fingers. And what's that for is that when I get to a resistance, the fingers slide. Right? I will do it deliberately.
Confusion. Then a lot of my supervisor guide me. When they said it, look up, then the big wheels go down.
Okay. Right. So right. Well, that's because when you're actually doing that, that's because of how you've got a loop. When you've certain loops will change the orientation of the scope. So when the big wheel is forward, right, that's what it should be. I keep the scope in an orientated manner, so there's no loop there. So I know. But if I put the scope forward and then do that anti-clockwise, it should go anti-clockwise. If I did this, it should go clockwise. And so it's just knowing that, and there is no loop. But that's how you asked about that. That's all it is. So you can have gel on your hands, no glove.
Is there any technique to cross the rectus sigmoid junction? Like, is there any technique because that's where the loop forms?
It's key. The technique is trying to keep the air to a minimum, trying to keep the scope in the lumen central, but trying to get your elbow down. If you notice when I was scoping, get the elbow in. You guys will bring the elbow up, right? So when you're scoping, some of us will be saying this and then doing this. I will actually touch it. So when you're standing there, I'll just go up next to you and make sure your body posture is right, because you just need to actually make you turn. You know, may do this. That means put your foot forward. You know, and changing your position opens up what you can do with the scope. So it's important that you know, I'm not just coming up behind you and going, right, come on. It's not that at all. I'm trying to get you to look forward at the foot, see where you're going.
Elbow must be down.
Keep the elbow down, because remember what I was saying about the arm. If you have the elbow up, you're going down to come up. If you have the elbow up, you're going out to come back in. So it's like going into the rectum away. So it's going into the rectum, you want it to go straight, but you want it to come straight in. If you're doing this technique, you're keeping this as straight as possible, this as straight as possible. The trick for someone who's experienced is to try and make it look easy. Yeah.
And movement of the body.
Again, if you notice, I use the hips a lot, and you have to, but keep the shoulders square. Well done. If you notice his scope is slightly off, the hand has moved a little bit, wrist is broken, so just keep the wrist straight. I don't have to be stood in front of him to know what he's not doing correctly. Right. Shoulders dropped, stand up, foot forward, foot back.
This forward.
Yeah. Less air. But what you're doing is looking at body posture here as well. That's it, good man. Now, if I was scoping, I'd be wanting that monitor here, further over. Good. You don't have to go any further. How was that? What are you doing? Are you doing anything different now to what you were doing before you came today? Paul.
Intentionally started using the small wheel sometimes.
No.
So I was trying to avoid
Right.
it. I was trying to use the
You can actually use it to flick around, and that just, again, on older scopes, you'll find that you will use the little wheel a little bit more than what you want to. Newer scopes, you won't. So again, don't think, oh, you said you can't use this, you can't do that. You can. Older scopes require a lot more respect. So yeah. No, what I'm saying is it's better to reduce your use of the little wheel as much as possible. But the big wheel is needed. Torque steering takes away and negates, for the most part, what the little wheel does. Because torque steering turns the tip and the orientation, and then you are then using the big wheel forward and backwards to make it turn the direction you want it to go. But there are times you have to use the little wheel. Right. I will always have, if that's in the rectum, I will always hold a scope back here, minimum. No, if that's in at 20 centimeters, I'll hold it 20 centimeters away, even 30 centimeters away. I will use it. So intubation, I'll use it here. Yeah. After it's in, I'll hold it here. 30, 40. And this is the important thing. If I don't have this, you got this is the important thing.
This is straight.
That stops it. If you notice, watch as it goes forward, it deviates. Just keep that there. It stiffens the scope.
So what I've learned by observing you that you use your fingertips more than the rest.
I use fingers. I let it roll, and then I support the roll with this hand. That's what you do. Well done. That's what I do.
This understand that
That there is just you're pointing the way, but you're pointing the way straight at the rectum. If you point the way, a lot of people scope, and I use the tips of my fingers. But
It's also easy to talk and
a lot easier to talk.
gives you more angle.
But the thing is while you're doing it, you're not gripping the scope, so you just support the scope in that angle, what you've got there, and then you can just let go of it, then grip it easier and more comfortable, and then you reduce your risk of any issues, injuries, carpal tunnel, all this stuff. Yeah, less pressure. You've got to protect yourself. You're young. You've got to protect yourself for the future. That's what you've got to do. It's very important.
and grip it tightly or
No,
loose.
loose. Now, what's happened here, it's classic, nothing against whoever's scoping. So when I say something, it's not saying you're doing something wrong or something bad. But what's classic is he stood what we all want to be. We want to be stood square to the screen. As a result, his hand's gone forward. If you look at his right hand's gone forward. So his right hand's gone forward to come back. I'm not watching, but I know what's happening. His shoulders dropped now to bring that back in. So therefore, he's got tension in his neck, and look at his back. Look at the leg when I said your leg goes straight. So he's going to get a bad back. He's going to get a neck. He's going to get repetitive strain into his. So you've got to look at the ergonomics. You've got to pay attention to how the room is laid out. You've got to stand where the screen is as square to you as possible to enable you to use it as much what you can. Try to keep this square. That's why I use the hips. That's why I'll do this. And I know that sounds daft, and some people say you look stupid. I do remember going on, we have a thing called bowel cancer screening in the UK. I went and did my assessment and many years ago, and there was a guy there, Chanel will know him, he'll tell you what he's like, a surgeon, well renowned, he's retired now, and he says, I don't like you're moving too much. I said, did it stop me getting to the cecum? He said, no. Was the patient in any pain? He said, no. I said, did I use any blah, blah, blah? He said, no. How long did it take me to get there? He said, 2.5 minutes. I said, what's your problem? So all I'm trying to tell, see now in 5 years' time, he's going to suffer. Don't want that. So we have to correct. So bring this hand down. No. Bring the hand down. Bring the scope down here. Yeah. Hold the scope here. And be proud. Your mother's proud of you. Come on. That's better.
You can also use water in separation.
So
Yeah.
the scope should be like this or it should be like this.
Yeah. He's actually he's cocked his wrist. Now he's going forward. Yeah, now he needs to go. Yeah, brilliant. Too much. She's telling you right. Listen. Right. What are you doing different to what the other guy? She's just told you without telling you. What's she asking you to do? No, she didn't say come back. She said slow down. When somebody does that, that's slow down. You're thrashing around at the moment. What would happen if you were in bed and you were kicking all around in the bed? What would your wife say to you? What would your wife say to you if you were kicking around in the bed? She'd clack you around the ear hole, wouldn't she? So slow down, man. That's it. Well done. Now bring that up here and relax. You don't have to go any further. You don't have to go any further. How did that feel? Okay. Did you do anything different to what you would normally do? What did you do? Now he's finding it difficult to actually apply the clockwise torque. What could he do? Let go of the scope. Let go of the scope. What could he do? Let go of the scope, man. Let go. Let go. Yeah. Hold the scope. Bring your arm up. Just bring your arm. No, bring your arm up. What does it do?
Gives him more air.
Yeah. So you're applying clockwise torque here. He's finding it difficult to apply. The scope is hitting here. He wants to apply clockwise torque. That has to feel free to go forward. It can't go forward while it's hitting here. It's like now he couldn't apply anti-clockwise torque because it's hitting here. So he'd have to then let go of the scope. Chodo. Right, I've learned something. Chodo. Right. Then he can apply it. So what you've got to do is look at how to optimize your body to get you to do what you need it to do. The scope. Okay, take it out. Who's next? Nope. Nope. Definitive. Nope. Never lock the wheels. It makes it stiff. If you have the wheel kick, if you have the scope tip off to one side and it's locked, you're going to be dragging that down the side of the lumen. There's always a risk to the valve.
Sir, do we have
Paul. Try Paul. Yeah.
Do we have to make the scope stiffer
Nope.
while we're drying?
Nope.
No.
No.
We have to use stiff.
You never. Retrosigmoid, splenic at worst. But what you don't want to be doing is having stiffness on as you withdraw. If you have stiffness on as it withdraws, the scope will come back, then it will come back, and the bow will drop off. If you have it on no stiffness, the scope will come back, and you've got more control.
While negotiating, so do we have to use the stiffness while negotiating the retrosigmoid?
No. No. Until you have difficulty. Just dropping it down will help. Clockwise torque. Now, if you remember what he did, put your arm underneath there. Arm underneath there.
Yes.
Yeah. Yeah. Regrip the scope. Bring your arm up. Just turn your shoulder. No, this way. Just turn your shoulder. Scope straight. That's it. You're sitting on the blow. You're sitting on the air. That's it. That's it. Good. Tip up. Often, so just let it off. There you go. And what supported that is your arm going underneath there. Because you were wanting to apply the clockwise torque and you were fighting it, you were finding it hard, you were feeling the weight of the scope was forcing that anti-clock and you were then trying to make it work and your hand was coming round. So putting that over enabled you to get round. That took the weight off the scope. Stop the blow. Draw back. Just a second. There you go. Anti-clockwise. Now, take your hand out from underneath it. That's it. Anti-clockwise. Good. He helped you out. Good. Excellent. Okay? And that's all you need to do, my friend. If you take it out. How did that feel?
I'm now giving more attention towards my ergonomics.
Yeah.
Previously, I ignored it.
If you think about yourself in this instance, and it's being selfish, and only thinking about the patient, but if you're comfortable, they've got to be more comfortable.
Exactly.
Okay. You'll go. Take it out for that. Just slow down. Brilliant. Lovely. Just freeze where you are for a second. That's it now. Good. Okay, you can stop there. How did that? Anything you've done different to what you would normally do?
I usually don't talk. I usually don't do that. And I
Excellent. So if we stop there for a second and take it out, then we'll just do one quick recap. So check this out. Eric, done. Done. Finished with this. Right. So guys, what are off, please, yeah. What have we done that's different? So we've introduced the idea that this hand can actually help this hand. Whereas before, we don't. This hand is going to stay still no matter what, so we're going to fight this hand and put up with the difficulties, thinking it's all to do with the bowel, when this hand can actually support it. Second, what else have we done? So ergonomics. So you're looking at how you actually feel yourself and comfort for yourself. What else have we learnt?
If we stuck up there, we have to come back.
But what's the most important thing? She pointed it out. Slow down. Okay. So the trick to this, colonoscopy is not hard if you slow down. What's the importance of slowing down? You come to a busy section on the road. Cars are coming this way. Cars are coming. I know it's Pakistan. Cars are coming straight ahead. Motorbikes are coming around you. I want to go straight on. What do? You slow down. You stop. You look there. And I know it's Pakistan. I'm going to take the mickey. It seems to me half the time you just don't pay any attention to what's coming out of the direction. You just go. But that's not what we want. We want you to actually stop, look, plan. The majority. It's interesting to watch how people negotiate the junctions here, because people do actually plan the route. And what do them? I'm thinking, all right, yeah, all right, yeah. They actually do plan the route. So this is what you've got to do in colonoscopy. You've got to plan your route. What gives you the best option to plan your route? Slow down. So taking your time makes you indirectly quicker, because you're doing less things. You're doing less movements that don't need to be done. We've learned that the right hand is supported by the left hand. We've learned that how to actually stand square to the bed, and our ergonomics is important. We've looked at and understand the concept of how air plays a part in what we're doing. You've looked at loops, and you've looked at how to reduce loops and how much scope you have to remove to actually reduce loops. You've looked at how much torque to apply. You've looked at how to actually assess what is a loop and how to reduce a loop. So in the space of an hour and 10 minutes, we've covered an awful lot. Well, that's what I'm going to say. What do you think? Has it been beneficial? I know you might not understand what I say all the time, but I'm happy to repeat. Happy when things are going on, we're happy to go through. There will be a room where the mannequin can actually be worked on, and then we're happy to work with you as well. That's the purpose of the faculty as well. It's not just what's happening. The importance of having the rooms played back into here and your procedures isn't to look at you, it's to make others understand when someone's having difficulty, regardless what it is, how to overcome it. And in here, you can critique what's happening. It's not an insult to the person that you're saying, oh, do you think they should be looking at this? They should be looking at that. It's to actually open your eyes into what's somebody else is finding difficult and then enable you to come up with solutions for that, what's happening. So don't feel threatened by what's on there. Don't feel threatened by any of the faculty, because the faculty are very well experienced guys. I mean, superbly experienced guys. And, you know, the ladies and the chat, it doesn't matter what gender, the people in this unit are immensely talented individuals. Immensely, right? They allow me to come and play. I'm happy to come and play. I just, all I can say is that the biggest, most important thing to do is enjoy what you do. If you don't enjoy it, you're not going to give your all. Right? So, anything you want to ask, anything you want to go over? Happy? Now, you'll hear me say happy a lot. And I'm genuine. I want to know if you're happy. If you're not happy, tell me. But it's very important. You look quizzical. Oh, you're fine. But you're not happy. So, okay.
I think we have like 10 minutes tea break, and then we have a small one of the presentations just to go through quickly after
Yeah.
the break. And then we have Dr. Satya as well. We just discuss something about anesthesia.
Brilliant. In this unit, you're going to be spoiled, right? And the reason why you're going to be spoiled, you've got some outstanding clinicians, but importantly, to support what you do here, you've got a great anaesthetic team. The anaesthetic team here is immensely talented, and listen to what they tell you, right? But at the end of the day, they'll help you more than what you think. Having somebody who gives the right amount and protects a patient's airway, etc., is the most important thing. It makes you look good when somebody is doing their job really well. And here, the anaesthetic team are exceptional. We don't have that. I'm very jealous of that in the UK, because in the UK, you have to book it. And then you have to book it, and it'll take 4 weeks before the patient can come in. Whereas here, you can come and say, right, it's coming to anaesthesia. Yeah, it's fine. So please have a break. Oh.
Whole presentation that we had of yours, so you can have to go to all of it, just the thing that you think.
Yeah.
Okay. So we'll do Dr. Safal have to leave at 11:30, so we'll ask her to do a short talk about
I think,
and then you can do this.
yeah, I'll do that. But
After that, do you want to do one case just yourself and show it, or you want to just do it?
I actually don't know the benefit of it, because they actually, I don't know. What do you think?
Or we just start with that?
I just think
I think we can just start the course. If you want tomorrow, we can give you, if the candidates, we can ask them that if they want to see a case, maybe tomorrow we can fit it in, because tomorrow will be nothing but hands-on. And I have 3 rooms for you tomorrow instead of 2. So we'll be able to, do a lot of demonstrations.
I think that every one of them you're going to end up taking over from. Yeah. And I think at some point in time. And I think then just showing them, I've always not been happy with it in the UK. Why should we show them how, not necessarily how good we are, but this is how you do it. Then the poor buggers are always trying to Yeah.
So what I was thinking was,
Just 1 minute. Just make sure this is closed
Oh.
before we.